Hello and welcome to this introduction to psychopharmacology. This is part one of the first lecture of the N232.04C nursing course for the UCSF School of Nursing. My name is Andrew Penn. I'm a psychiatric nurse practitioner and an associate clinical professor in the UCSF School of Nursing. So what we're going to talk about first is some introduction things that you want to be thinking about before you even begin starting to prescribe medication, considerations before the prescription pad even comes out. Now, for many of you, this is one of the most exciting moments in your career, and I say that not just because I'm teaching it, but because I remember when I first learned how to use medications, it felt a little bit like I was in Harry Potter's advanced potion making class, and in it I was going to learn the secret scripts of psychopharmacology. And there's something to be said for that because when you look at how we write a prescription, I mean, look at all these arcane symbols and abbreviations that we use that are based in Latin. When you get a script, you can hardly read it, let alone make sense out of what the different terminology means. But we're going to learn that, even though most of the time we'll be writing our prescriptions on computers. But nevertheless, I want to teach you how to be a nurse psychotherapist who also happens to know how to use medications. So while this class is psychopharmacology, I want to be really clear that that is not your only skill set, but only one of several that we're going to use to help our patients. But primarily, our psychopharmacologic relationship has to be embedded in a psychotherapeutic relationship in whatever form that takes. But yeah, I want you to try and take out of your mind this idea that you just do the medications because you do far more than that. And I want to also get across that there is both a science, which you might think of as a craft, but there's also an art to psychopharmacologic practice. So just as I could teach you how to use a hammer and a saw, you would not be a carpenter. You would, to become a carpenter, you need to not only know how to use those tools, but you need to understand how materials work, design, proportion, scale, etc. That's all part of the craft of what we do, the art and the craft of what we do. So I'm going to teach you how to use the tools, but it's going to be in your clinical site where you really begin to understand the art of this kind of work. But it's important to understand that both are essential. And I also want to really emphasize that medications are just one of our tools that we use. This is a kind of a cute cartoon that reminds us that there are many wellness practices that complement and accompany our medication treatment. So we should never think of treatment of a patient as only to do with medications. We may be focused on the medications in our role, but we don't want to forget that there are these other important things such as meditation, diet, exercise, relationships, sleep, humor, getting outside, psychotherapy. These are all important aspects of wellness, and we don't want to forget about these in our focus on medication. So what is psychopharmacologic informed psychotherapy? Well, it's the science of using drugs that change the way neurons communicate with each other. And by doing that, we might be able to succeed in changing mood, thinking, or actions. And it's also using the art of your relationship with the patient to combine these treatments, as I mentioned before, not only the medications, but these other wellness practices for the sole goal of helping the patient get better. Now, for many of you at this stage in your training, you're towards the end of your first year, you are in this growth trajectory. And it's kind of an uncomfortable place to be because at first, when you first started, you didn't know anything. Well, you knew, you didn't even know what you didn't know yet. So you're unconscious of that which you were incompetent. But as you started to train, as you started to spend some time in clinics and in hospital with people who did know what they were doing, you started to realize that, boy, there's a whole lot that I don't know. And then you get to the place where you start to know how to do it, but you have to really focus. Think about maybe when you were going through nursing school, the first time you had to put a urinary catheter in. You could do it, but you really had to think about keeping that dominant hand sterile and not contaminating your field. And then after you do a few hundred of those, you can do it without even really thinking much about it. It just becomes muscle memory and second nature. So another way of looking at this is Patricia Benner's work around from novice to expert, and to think about how most of you at this stage in your careers are somewhere at the level of an advanced beginner, and you're right on the cusp of starting to develop competence. So you're in this uncomfortable place of knowing that there's a lot that you don't know, but you haven't gotten to the place yet where you feel comfortable with the things that you have yet to master. And that's okay. I want to invite you to welcome that discomfort and be okay with it, because that's where we're going to work for the next 10 weeks. So that's fine that you don't know yet. You will know a lot more by the time you get out of this class. So another way I think about learning is that, if you've spent any time outside in Northern California, you've noticed that there's these big black birds. They're turkey vultures that fly over the hills. And they fly over the hills, and they fly on these thermals of hot air that rise off the ground. And you'll see them fly around and around in big, big circles. And I imagine, what was it like to be one of those turkey vultures? Does the turkey vulture look down on the ground and think, oh my gosh, I'm over that barn again. I can't believe I haven't gotten anywhere. And a lot of times when people are new at learning, they get frustrated because they think, oh my gosh, I can't believe I still can't remember the other name for sertraline. It's Zoloft, by the way. But they can't remember, so they get frustrated with themselves. But then, after repeated passes over the same information, you begin to take it in. And I kind of liken that to, so this turkey vulture is flying over that barn, and it looks down and it says, oh my gosh, I can't believe I'm still over that barn. I haven't gone anywhere. But this time it kind of looks left and right. And it says, wait a second, maybe I know more than I thought. Maybe these things that I'm passing over, I start to see how they connect. I start noticing that beyond that barn is a road, and that road goes over that hill, and I never knew over that hill was the ocean. So there's this sort of process of circling over the same material, but each time you pass over it, you're at a higher elevation, so you get to start seeing the bigger picture. And the bigger picture in the knowledge distribution starts looking like this. You start connecting what you know to other pieces that you already know, and you start putting the big picture together. And I'll tell you, even though it's been over a decade and a half since I completed my training, as I'm preparing to teach this class, I'm still learning new things. I'm putting together new connections, and I'm understanding things that I had a cursory understanding of 15 years ago, but now I understand them on a deeper level. And I want to encourage you to maintain that kind of curiosity as you go forward into your own practice, that you're going to lay down a baseline of knowledge in this class, and then as you go forward, you're going to add more and more information to that knowledge. You're going to take it from a higher and higher pass. And, let's remember that what we're doing here this is not abstract. This is ultimately a very human practice. We are engaging with people sometimes during the most difficult times of their lives. And this is a encouragement, an admonition, an invocation for you to be a good person when you're as a practitioner, and to think about last time you were a patient. Every time I get sick, I'm getting over a cold right now. If my voice sounds a little funny and I'm coughing, forgive me. But if I get sick and I have to go see a medical provider, I feel like a secret shopper. So I get to see what it's like on the other side of the exam room. And it's interesting the things you notice when you're in that role. You notice little things like, does the person make eye contact when they come in the room? Do they shake your hand? Do they put their papers down or put the computer aside and listen to you? Things like that make a big difference in how a patient experiences the encounter. Because there's that old saying, I think might have been Eleanor Roosevelt, that said, people don't remember what you said, but they remember the way that you made them feel. And I've definitely experienced that in my own clinical practice, that people remember feeling safe and comfortable much more than they remember how smart you are. I mean, you need to be smart too, but you also need to to help people feel comfortable. And so this is a great little set of tips. This is in CLE. You can print this out for yourself. And it's just a great guideline for how to do good clinical practice. So there you go. So before we get our prescription pad out, what do we need to know? Well, first of all, we need what we call HPI, history of present illness. So that is a full history of the illness, including how it has impacted the patient's ability to function in the world. When we talk about functional impairments, we're talking about how has this impaired your ability to be a student, to be an employee, to be a parent, etc. Okay, to be a partner, to be a friend. Those are all functional impacts of the illness. So if somebody is depressed and they're not getting out of bed and they're missing work because of it, that is a functional impact that is separate from the subjective misery of the disease. So it's also important to understand what is the goal of the patient, because the patient may have different goals than you do, and you shouldn't assume that you have the same goals. So I might ask this in the form of, so when you made this appointment today, what were you looking for? What were you hoping what we would do? Because that way we kind of get the agenda just right out at the beginning. Because the person may say, I have a sibling who takes X medicine, and I'm wondering, because my symptoms are kind of similar to my siblings, could that X medicine be good for me too? Well, we could talk about that. We can explore that. It's also important to know a psych history. What past treatments have been tried? Because we don't want to make the same mistakes twice, right? This will help. You can also start teasing apart what sort of diagnosis might you be dealing with based on the past treatments. Because there's a genetic component to many of our illnesses, it's helpful to know a family history, also including response to medications. Medical history. We want to know what medical issues are present and what medications the person is taking. We want to know what substances they use. And we want to do that in a very delicate and thoughtful way, in a way that's non-pejorative, that helps people feel comfortable answering what can often be a very sensitive question. A mental status exam is a snapshot of how the person looks today. I used to get kind of flummoxed by MS mental status exams because it was hard for me to tease out the subjective part of the exam from the objective part. And the mental status exam is technically the objective part. But it's a little murky because we ask things like mood, and that's subjective. But if you can forgive those inconsistencies, the mental status exam is essentially asking us, what do we see as the examiner looking at the person today? The diagnosis is a working diagnosis. Often by working, I mean it will change. And then the plan is, how do we get to the desired goal? So in this case, we're going to be focusing on the medication aspect of getting to that goal. Now, I want to caution you. It's really tempting when you're doing an intake with a patient to be listening for symptoms that you can cherry pick, and you end up cherry picking them into a diagnosis. So you might hear somebody say, sometimes I go for 2 nights without sleeping. Now, if you are looking for bipolar disorder, you might hear that and think, aha, I've found it. I know this person is bipolar. When there could be many other reasons why that person is not sleeping, but it's important not to start having a selection bias where you begin hearing only the symptoms that are congruent with your preferred diagnosis or your suspected diagnosis. Because a lot of times what ends up happening is you then jump from a diagnosis to your treatment plan and your prescription, and the person hasn't even really finished talking. So your challenge when you first start talking with a patient is to reserve judgment and to kind of keep a broad field approach. And if you think, no sleep for 2 days, that's interesting. Let's make note of that and then ask for other symptoms that might constellate around that. So my next question would be, I would say, so you say you haven't slept for a couple of days. Does that happen frequently? And they say, yeah, it happens once a month. They say, well, how do you feel the next day? They say, oh my God, I feel so exhausted. I can't wait to go to bed. Well, that's probably not mania. But if the person says, oh my gosh, I don't sleep for 2 days, and the weird thing is, I don't even feel like I need to sleep for the third because I've got even more energy than I did 2 days before. Well, then I start asking about other questions that might be related to bipolar disorder. You see where I'm going with that? But I still remain open to diagnostic possibilities. And one of the possibilities is the person has more than one condition present. That's very common in psychiatry. Now, when we're making a diagnosis, it's tempting to, because we're learning about all sorts of amazing things here at UCSF. We're learning about all sorts of rare and esoteric things because this, of course, is a tertiary medical center. So people come here from all over the world to have their unusual uh, conditions treated, which no one else in the country knows how to treat. So you might see things when you're in training here that you're just not going to see in a community hospital in the middle of California, for example. And so it's tempting to start thinking that all these things that we see are these rare esoteric conditions. And, we also want to show off a little bit for our preceptors and so somebody comes in with panic symptoms and we say, is it a pheochromocytoma? Well, it could be, but most likely it's panic attack. So I want to introduce you to this idea that was written about by William of Occam uh, centuries ago. So this is known as Occam's razor. And he said, all things being equal, the simplest solution tends to be the best one. Now, he was talking about just logic in general, but this is a very useful principle to use in clinical medicine. So the way that we often talk about this colloquially in medicine is we say, when you hear hoofbeats, think about horses, not about zebras. So sometimes rare medical conditions that look like more common medical conditions are referred to as zebras. So in general, you're going to see mostly horses. Every once in a while, you might see a zebra, but most of the time, you're going to see horses. So does everyone with a psychiatric condition need medication? Absolutely not. Here's where I think about when people need medication. So when somebody's essential functioning is impaired because of psychiatric symptoms, they might benefit from medication. So when I say essential functioning, this is somebody who cannot get out of bed to go to work, to go to school, to take care of their kids, to show up in their relationship. That's essential functioning. Or when the suffering associated with those symptoms of that condition have become unbearable. Now, this is obviously more subjective. Some people will have a headache for days before they will take an ibuprofen, and other people will take an ibuprofen at the very first sign of a headache. Is one person better than the other? No. They just have different tolerances for suffering. There's no virtue associated with that. It's just individual variation. But there will come a point where somebody says, you know what, I've been feeling anxious long enough. I'm going to call and see a psychiatric NP about, is medication appropriate for this? And so a lot of times, by the time people have made an appointment and come into your office, they're suffering enough that they want to do something about it. And the other place where I think medication is indicated is when symptoms of their psychiatric condition become such that they're not able to avail themselves of other kinds of auxiliary treatment. So for example, somebody who is so depressed that they can't get out of bed and show up in psychotherapy can't benefit from psychotherapy. So medication might be just enough of a tool to kind of get them out of bed and a little less depressed so they can start benefiting from psychotherapy. Now, what about informed consent? Is informed consent just some form that you check off in the process of giving medication? No. I mean, it may be ensconced in a form, but really an informed consent process is not a formality. It's essential. And it's essential because what it does is it develops trust between the patient and you. And informed consent is a process of talking about the risks of the drug are, what the benefits of the drug or treatment are, and what the alternatives to that particular proposed treatment would be. So sometimes you see that abbreviated as R/B/A. But really, that is a living conversation that happens over time. And you may want to repeatedly document that you are having informed consent conversations. So for example, somebody may come in after taking a medication for a month and say, oh, I'm noticing this side effect. And you say, yeah, that was We talked about that in our first conversation, and here's the things that we could do about it. We could stop the medication, we could lower the dose, we could change the medication, we could add a different treatment to help um, alleviate that side effect. So those are all risks, benefits, and alternatives for that drug. So now, should you talk about every possible side effect of that drug? No, you can't, because the reality is that these, if you take out your micromedics or Hippocrates, you'll see that there's a list as long as your arm for most of these medications. So this is where the art comes in. You need to be able to tell people really off the top of your head what the most common side effects of most of the medications that you're going to use most commonly, what those side effects are, the most common ones. You also need to be able to tell them what the most serious side effects are, even if those side effects are rare. Because let's say, for example, a drug like lamotrigine or Lamictal, there is a rash that we'll talk about when we get to the bipolar section of the content called Stevens-Johnson syndrome. Exceptionally rare, but very serious if it should happen. And if somebody should get that and you didn't tell them that's a possibility, that's not going to reflect well on you, and that could potentially subject you to malpractice. So you want to talk about the most common side effects because that's what's going to maintain your credibility, okay? And that's also going to help the person feel safe and comfortable with you. But you also need to talk about the most serious side effects, even if they're rare, and to put them in context that say, so for example, Stevens-Johnson syndrome is something that happens to about 1 in 10,000 patients. Most people will find that risk acceptable. Okay, so that's the first section of our Introduction to Psychopharmacology. In the next section, we'll talk about how to actually start a medication.